Introduce Dr. Grace Sun, an associate professor of ophthalmology at New York Presbyterian, Cornell Medicine. She graduated from Stanford University with honors and later received her MD from Cornell and completed a residency in ophthalmology at Cornell. And she's the site chief of ophthalmology at New York Presbyterian Lower Manhattan Hospital. She has a strong interest in medical education. She served as the ophthalmology residency director for 10 years at Cornell. And she is currently the Associate Designated Institutional Official of New York Presbyterian Hospital Cornell Medical Education, overseeing the clinical learning environment of over 65 training programs across all medical subspecialties. At the national level, she was selected by her peers to serve as president of the AUPO Programs Directors Council in 22 and 23, and is currently the vice chair of ACGME Ophthalmology Review Committee. Rachel, she's a good person to know. Okay. Additionally, she is passionate about global health, and Dr. Sun serves as Peace Corps volunteer in Nicaragua and currently leads Cornell's efforts in global ophthalmology in Tanzania. She also volunteers with Orbis International, teaching cataract surgery in South Africa, China, and Peru. Dr. Sun has held multiple leadership positions, previously as our president of the New York State Ophthalmological Society and president of Women in Ophthalmology. Please welcome her as she presents Developing the Competent Cataract Surgeon. Welcome.
Good afternoon. It's such a pleasure to be here. Thank you for the invitation. Thank you for making everything so welcoming. I really enjoyed the culture of the department that I have already gotten the sense of camaraderie, of family. You know, if you're hiring, I may consider Rochester. It's my first time in Rochester. Oh, that's true. Don't show this to Don. So I'm so excited to talk about my passions, which include cataract surgery and, more importantly, teaching cataract surgery. One of your residents had asked me earlier what was my favorite thing about being program director, what was the best thing, and it's the residents. It is truly the residents and watching you grow into develop this professional identity, and that's why we're in academics. I think I speak for most of us in the room. So I'm going to speak about developing competency as a cataract surgeon. I have no financial conflicts of interest to disclose. I do volunteer for the ACGME RC. However, what I'm going to talk about is not an official RC recommendation. They're my own opinions. Okay, what is the significance of this number? I know Rachel knows, so.
Minimum number of cataracts required for graduating.
Did you know that? Yeah, you do. So it's such like ingrained in our psyche, and we're gonna talk about this number, where it came from, what does it mean? I think it was 45, actually, because it got to 86 when I graduated, and we're still there. So the current minimum is 86. It was set in 2007. I graduated in 2009, so I did the 86. It wasn't based on studies, on safety, on competence, on efficacy. It was just based on what was the 20th percentile of all cataract surgeries performed by residents that were reported. Previous to that, it was 45. We only started our procedure logs in 2002. So we've been staying at 86 for a while. So I talked to the residents about how they are educated in cataract surgery. It sounds like we're all trying to move towards earlier exposure because we want them to be set up for success. And I'm not sure if this is going to work, but this is what we prepare you for. Like, you're about to jump in, dive in. This is courtesy of Tom Oeding, one of our colleagues. Like, you're ready, right? Like, you did your icy, you did your Kataro. Oh, but that's no good. How do we avoid that? Right? We want to build you up. We want to set you up for success. Does it have anything to do with 86? I don't know. So we're going to define what competency means in cataract surgery. We're going to describe what may be the resident cataract surgeon learning curve, and then we're going to talk about some of the things that we do as educators in terms of teaching and assessment. So we have until 5 o'clock? Four?
Dinner's not till 6.
The audience may not feel the same way. Okay, so I think many of us are familiar with this TED Talk book by Simon Sinek. It is on leadership, and we want to start with why. And I think maybe particularly to a chair, we think about what we do, what the organization, what does Flaum Eye Institute do? And we think a lot about how we do it. And oftentimes the why is later in the background. But I argue that when I think about why I do what I do, because teaching cataract surgery is challenging, it is so many reasons. And it's the purpose. What is our vision? My vision is for all of you who may eventually practice as cataract surgeons, to be a safe, reliable cataract surgeon for our community. It's about patient care. So taking a step back, one of my other passions is global ophthalmology. I've done surgery in other parts of the world. Cataract is a leading cause of blindness, and it only continues to grow. So not only in parts of sub-Saharan Africa, obviously, the demand for cataract surgery in the US is going to surge for a couple of reasons. One is that, aging population, cataract surgery is the definitive treatment for vision loss, and our ophthalmology workforce will continue to diminish. So there was this great article a couple of years ago in the Blue Journal where the projections are pretty dismal. So the supply is going to decrease by 2,650 full-time FTEs of ophthalmologists, 12%. The demand will continue to grow. Obviously, a supply and demand mismatch, and it reflects about 30% workforce inadequacy. Of course, this will be highlighted in our rural and our underserved communities. And then by 2035, we are going to be the second worst rate of workforce adequacy of 38 of our medical and surgical subspecialties. So that's not good. So we have a great treatment. We may or may not have enough ophthalmologists. So we have to train you to be competent. But, another thing. So many of you will do fellowship. In fact, there's more studies that our residents are going into fellowship, but some of you are going likely into comp, going into the community. Cataract surgery, that's another talk. And another 26% will do something anterior segment, where you'll probably do a little bit of cataract surgery. Their perception of ophthalmology graduates is that while most of them feel like they've got good training, clinical training, and they're prepared to practice for comprehensive ophthalmology, almost 2/3 reported that they perceive the need for additional surgical training. And what was reported, and this is a little bit of an older study, but refractive surgery, and then some of the subspecialties. But despite our main surgical procedure that we teach in residency, 14% reported that they wanted more experience in cataract surgery. What is more concerning to me is that program directors report that some residents, and I'll go over the percentage, struggle to achieve surgical competency. So this is an older study by Dr. Beinbaum and Dr. Volpe. It was in 2001, and they sent a survey to program directors, or program directors responded, and what came about was the realization that program directors think about 9% of our graduates really struggled with surgical competency. And about a third of them overcame these struggles by graduation. And of those that didn't necessarily overcome these struggles, a certain percentage did non-surgical ophthalmology. Some percentage did, 20% did fellowship. 12% got additional mentoring and practice, and then about 12% didn't graduate or left the program. So this study was repeated, and this one was from 2019 with some of the same authors. And it was a higher percentage of program directors responding in this survey, but still about 7% had difficulty mastering surgical skills. And about 84%, or significantly more, were able to remediate. So what does this bring up? The concern is that program directors are signing off on our residents, some of them who may not be able to independently practice, and they're signing off on their ability to sit for the boards. So the competency-based medical education that we have in the ACGME, there's 6 competencies, professionalism, medical knowledge, patient care, communication, systems-based, practice-based, we know that. But in a surgical subspecialty, the 7th competence is surgery, because we are, and the conversation has been had with the ABO, the Board of Ophthalmology, that we are a surgical subspecialty. So you have to be competent in surgery. And in response to the second survey, Dr. Getty's study, Dr. Bartley, who is stepping down, but led the ABO for years, a competent surgeon is able to make the diagnosis, so the pre-op, knows if surgery is appropriate, and then executes the technical aspects of the procedure safely and efficiently, post-operative care, and then interacts effectively and ethically with the patient and the family. So part of the why is that patients and the public put their trust in us, in the educational institution and the certifying organizations. So we have to take that responsibility with integrity. The milestones are this developmental pathway, like you all are, come in as infants, and then you graduate over the 4 years with this progression of novice to learner to competent, and then the goal is for most competencies to be at a level 4. And how many of you are part of the CCC, the faculty? So there are actually milestones for cataract technical skills, and I don't know if you all look at the milestones for technical skills as part of the CCC, but they do exist. And so someone who is a PGY1 may assist, and that's a level 1. But someone as a PGY4 is independently performing cataract surgery and is thinking about when is it appropriate to do torics, is managing complications, and recognizes and manages, for example, lens fragments, retains lens. So are we doing that well in training? The level 5 is a level of an expert, so not necessarily something that we achieve or attempt to achieve during residency. So the question is, how do we define cataract competence? So we use these surrogates, right? We have this looming 86. Is it the number that you do? Is it how efficient you are? Is it your complication rate? Is it visual outcomes? Do your residents track their cataract visual outcomes? Some of us do, but that's something that could be a QI project, for example. For every graduating residence, you should look at your pre-op, your best corrected 3 months after cataract surgery as just a quality improvement project, so to speak. Or is it time-based training? Like ophthalmology is 4 years. By the end of 4 years, you're competent, right? And obviously the short answer is no. We're moving towards something called a competency-based education, where clearly 86 is what the RC accepts as minimum, and it's not a target, and achievement does not signify competence. That's what it says in the ACGME, because many people think, oh, as long as I've reached 86, I'm okay. So there have been multiple studies about characterizing the learning curve in phaco and trying to figure out what is surgical competence. So this is a study from Colorado, and they basically broke it up into, can you complete it without assistance? You're able to complete it, but you needed some assistance, or, I really didn't need to be there. So this is sort of a very simple way of thinking about it. And it was 9 residents evaluated, 4 attendings, and residents appeared to become proficient around 75, but not necessarily so in what are the most difficult parts for you for cataract surgery. Everything was really easy. Yeah.
Subincisional cortex removal.
Yes, cortex removal and also nuclear disassembly. So those were the most difficult that were identified. And 90% of resident cases did not reach this level 3 until they exceeded actually 100 surgeries. So the complications, that's another marker for competence, so to speak. This is a study done out in Emory, an older study, but it was looking at the 2 more common complications, the posterior capsular tear and the vitreous loss. So almost 700 resident cases. In most of these studies, there is no difference in final visual outcome, by the way, when you measure out. So we looked at these complications, and there's an interesting sort of inflection point. So there's a little peak at around 80, and then it starts to go down, but then it kind of rises again at 150. Why do you guys think that happens?
Overconfidence.
It could be overconfidence.
Complex cases.
More complex cases, the attendings are willing to let you do more, etc. But the point of this is that you're not done, or most of you all, myself included. So when I graduated, it was 86. I think I did 100. And I can tell you my story of my first year as an attending teaching. That was not a good year, because I think I needed to learn how to teach, and I needed more complications. So that's a whole another thing that Rachel and I could talk about. But so the complication rate started to plateau around post 160. And efficiency, phaco time, essentially continued to decrease until, well, I think they stopped measuring post 200. So you become more efficient. This is a more recent study out of Michigan, which was presented at AUPO, and it's similar. It's PCRs and vitreous loss appear to decrease significantly at around 150. But look at how steep that curve is. Like between 50 and your next 50, there's a huge learning curve, but it continues to develop. Complications, there's a period of rapid improvement at the beginning, and then there are these little bumps and blips, and it starts to plateau. This study also said after 160. Now, the limitations here with these were self-reported, 26 residents. Canada. So Canadian system, they do way more cataract surgery because they have an extra year. So they're doing like 700. And I'm not advocating for that. But in the first 4 weeks of measurement, that's when they first do about 40 cases, and their complication rate increases later when they're doing their next 80, so about 120, and then it starts to decrease. So this trend, again, is clear: decreased odds of complications. Again, no real difference in visual acuity. So this is the largest study of date. This looked at the VA, and this looked at nearly 400,000 cataract surgeries, 100,000 or so done by the attendings, and then just over 300,000 involved a resident. So what did it show? The resident complication rate was higher, which is not a surprise, but that the higher resident case volumes were associated with lower complications rates, meaning PCRs, dropped nucleus, zonular loss, and then hemorrhages were low in general. And then case length also decreased from 38.8 minutes to nearly 23 minutes after 200 cases. So there's more and more evidence that, at 80, there's some sort of proficiency, but not necessarily competency. This one is another one out of Emory more recently. And what they did here is they broke up the cataract surgery into all of the different parts and looked at what 50 cases were, like group A, the first 50, second 50, third 50, etc. And the learning curve continues post 250. And essentially, there's a significant decrease in operative time. And the largest drops were in that areas of, for example, nuclear disassembly and cortical removal that continued to decrease time later on. So at some point, we're thinking, well, if more seems to be better, we should just be doing more. Not necessarily. This is one that came out of Mass Pioneer, where they looked at over 2,000 cases, and they were just looking at time. And at post 150, it plateaued, and there was no significant improvement beyond the first 150 cases. The more interesting part of this article to me was that it characterized like 3 phenotypes of learners. So for our faculty, we kind of have experienced this, right? So you have those residents who seem to know what they're doing immediately, and they progress pretty rapidly or as expected. And then you have those, perhaps it's a little less confidence at the beginning, or they struggle, but then there's a trajectory of normal development, rapid improvement. And then you have this third group in the red, where it's a slow start, and then there are these like fits and bursts, and they don't really progress. And that's what we want to identify, right? How do we identify those that are sort of like my colleague Susan Collican, who is also very interested in this, she called them stuck in neutral. So our goal is to identify those residents because, and this is her slide, so she's been 15 years as a PD. And she's like, oh, we've all had that story of that one resident who has golden hands and they just like go in, they know what they're doing. Not very common. The typical learner is a large majority of our residents who just, they do more, they grow a little, but they're typical. How do I identify the residents that need intervention? And then she called them the heart failure ones who probably surgical, ophthalmology may not be the best fit. So where do we define that line of competent for the group? So it seems like the number 150, 160 has been coming up in many of these more recent studies. When Dr. Volpe and Benbaum did their first study, and it was 2001, where 9% of residents struggled, 30% were able to remediate, but then you had a whole bunch that, didn't really progress. At that time, the median was about 104. So part of the thinking is like, well, maybe they just never had the opportunity to get to that part of the curve where they developed confidence. And then when Dr. Getty did his study, which was it was in 2019, there was only about 1% that was not able to remediate. And again, maybe those are the ones that we, have a conversation with or do something, that maybe they don't want to do cataract surgery. Maybe they need fellowship and some other specialty. But the issue with the program director is that it's really hard not to sign off. They've invested so much. But again, our educational goal is to produce residents that are safe into the community. So the bottom line is maybe it has a little bit to do with how efficient you are or your complication rate and your visual outcomes. It's certainly not this structured for your artificial end to your training. And it's not the number of surgeries necessarily. It is about entrustment of that signing off of like, the resident was able to do it alone without intervention consistently and safely. So the bottom line is that complication rates improve through 120 cases. There's a little, worsening at 150 for the reasons that perhaps we've discussed. And that case time continues to improve with the fastest gain in the first 80, which is why maybe people were comfortable with the 86 number because you can maybe get through. But you reach a plateau at 150, and then some of the other studies say you need more than 300 to reach that second learning curve. So it's not 86 is my hypothesis. The good news is, and I don't know your numbers, but the median cataract number for programs has been growing, and it's over 220 now in the last year. The question of is it an arms race is a real question because there's a balance. You do more cataract surgery, you take time from something else that you actually need to learn in the short period of training. So that's something at the programmatic level that needs to be discussed. But the numbers, and obviously that low dip is COVID. Most of us are already doing over 200, in part because I think the residents and the faculty know that the 86 is just not enough. I've spoken to many of my residents who don't feel that 86 are enough. Okay, so how do we get there? I think you're doing this already from what I know of the program and my discussions with the residents. So the impact of a structured surgical curriculum, this is an article that was done in Iowa, and it was one of those natural studies where they implemented this structured surgical curriculum versus just go to the wet lab culture. And the implementation of having structured curriculum that is in part staffed. And now, Rachel, there is an ACGME requirement that actually wet labs need to be assessed. So there has to be some assessment. So this was statistically significant in reducing the number of sentinel events. So I saw this fabulous wet lab with the hog straight, the icy, that's amazing. When I was program director, one of my first things was also to get the icy in 2012, I think. It was really hard to make sure the resident actually did what I asked them to do and to have the accountability. And I would say you can't come into the OR until you've shown me that you've done CAT A and B. But once they're there, you feel bad, like, oh, you're here, I'll let you do something. You really have to hold the residents accountable. Sorry. But it is deliberate practice that there is evidence that CCC, the capsulorhexis module really works. So we started the AUPO SCORE program, which some of the residents attended. And what we'd like to do is actually bring it locally. You can do the SCORE lab here. You don't really need to send the residents, but please send your residents if you'd like. But it's the goal that you go to this wonderful institution and you have all of the resources. You have this beautiful lab, but what if you go to a program that's smaller without the resources? So the idea, the why, was that we need to train cataract surgeons or just surgeons in general. We want to make it accessible so we can graduate competent surgeons and take care of our patients. So there is a standardized online curriculum that everyone can access. So right now it's mostly advanced cataract, but there's some laser stuff, there's some ergonomics, there's suturing. So you don't have to go to the academy lab, but there's that online curriculum that you can actually monitor if they've done it. So you can get a little score sheet and what they performed pre-test and post-test. There's that hands-on wet lab curriculum in which you're assessed during the curriculum. And then there's a teaching the teachers or training the trainers curriculum, because cataract teaching or surgical teaching is not just because you know how to do the surgery and such, you're now a great teacher. And one of my biggest mistakes, I think, when I was program director, is that when we had young new faculty who wanted to teach, I was like, sure, you good, I need you to teach cataract surgery. And they had one of their worst days because they did 3 anterior vitrectomies and they didn't want to teach anymore. So there's something about being an educator that requires some additional training. So to the residents, use the LMS. I'll make sure you know how to log on. Assessments are critical in terms of the learning curve and investing in faculty development to learn how to teach. So in the SCORE program, we have some AI generated multiple choice questions. And what we're doing is we're trying to get a group of institutions who have this hog straight system to upload their videos. And one of the things we'd like to do is do AI assessment of videos. So that's to come. But surgical teaching. This was a general surgery study where what makes a good surgical teacher, you got to engage the learner. They're adult learners. You don't tell them what to do. They know what their issues are. You involve them in the planning. They have to diagnose what their own needs are, formulate their own objectives, and then they need to identify the resources. So you have to create this supportive learning environment, which I can tell this is an institution that does that. And you involve the learners in every step of the way. The most critical thing is that giving feedback, teaching, this takes a lot of time, and there are so many pressures on our faculty and our institutions I was talking about this idea of not RVUs, but educational RVUs, which hasn't actually worked in our department. But, you know, many of us rely on the generosity of our faculty, and that's why we're here. But we also need to invest in our own faculty to be trained to give feedback, which feedback is difficult to track unless it's electronic. And so, for example, after the OR, after every case that the resident does, it's 1 minute. I ask them, so what did you think? How did that go? And then the tell is what I observe, no judgment. You know, I noticed that the Rexis went out to 3 o'clock and you struggled to bring, or that's not struggled, but we, that unable to bring it back in. And then ask about what are we going to do? How do we plan? How do we work together to do that? So it's a minute after every case at best. And so there's clear benefits of workplace-based assessments, such as feedback and such as the next slide that I'll show. One of the things that I've learned when I was on the CCC and program director is that there is an undercurrent of like, oh, this resident did well. And then suddenly this resident develops this reputation of doing well. And then suddenly the attending is like, oh, this is a good surgeon and I'll give them more. But then you can also be biased the opposite. So we want to base our assessments on something that's objective. And we can use something like the Oscar, which no one's going to use. It's lovely. It was developed by the ICO. I mean, purposely you can't read this. But there's something that Robert Swan has shared with the community. It's, again, less than a minute. Name, your name, what procedure, how difficult, or what type of procedure, and then how complex it was, and a global assessment. I had to do the whole procedure. I had to help them with the procedure, talk them through, prompt them time to time. You can develop your own, but this goes automatically pushed from the resident. And then Seth Patinelli has developed, it's almost like a color-coded graph where it takes all the information from this global assessment, and then you can see how the residents progress over time. And it's great for the faculty to know where the residents are, and not like I'll call up the cornea surgeons and say, so how did so-and-so do? And then I'm just relying on their feel. So the final thing is 86 doesn't equal competence. Is there a number? It's different for all of the residents. For the program level, again, the ACGME accredits programs. It doesn't have anything to do with individual residents. My guess is it's somewhere around 150. So I'm just, we're going to go on a listening tour because that generated a lot of discussion after the AUPO meeting. Is more better? Not necessarily. We want programs to be innovative. If you're not going to be a cataract surgeon, maybe maybe when you meet 150 or whatever it is that you're competent in, you should spend more time doing something else, because we do want competency-based education. And, we want you to be innovative. We need pediatric ophthalmologists. Maybe you should create something that has a different path so that we can meet the public's needs. So innovate. These are my resources. This is a big thank you for being so warm and kind today. And these are some of my past residents. Only like 2 of them are doing cataract surgery. And some of my colleagues who have been with me through this process. And Dr. Feldon, I know he wasn't here, but obviously has been in this institution for a very long time, was a champion of SCORE. So I wanted to send some gratitude to Dr. Feldon as well. 5 o'clock.
How femtosecond laser-assisted cataract surgery play into that? I mean, I would think that would be decreasing the number of cases that are needed because of the technology helping with the
Yeah.
How these new technologies play into.
So one of the thoughts when there are new requirements starting July 1 this year for residency training. And I was part of the writing group. One of the things we thought about was, well, should we require a certain number of simulated surgeries to reach that first, assessed, and then you operate on a human being? In the airline industry, it's simulation, and then you kind of fly 500 people into the air. With femto, I agree that there's certain parts of that surgery that are easier, and there are certain parts that are actually harder. I've had my residents participate in femto laser assisted cataract surgery. They no longer are certifying residents for it, so when you have the patient population who is paying over $2,000 for that, it's really hard for the resident to do that. But I think there's new technology that has made cataract surgery safer. That is one of the reasons why you don't do as many anterior vitrectomies, I think. There is still a need to learn anterior vitrectomy, of course, and there have to be opportunities for that, but I think simulation has to be part of it. And the simulation that we've had in the past have not been that great, honestly. And the models that we have are not perfect, but they're better than, doing your first surgery in somebody's eye, I think. Yeah, Rachel.
So I do think there are probably a small percentage, maybe it's about 1%, that probably really never can master cataract surgery, whether it's like a physical, whatever,
Yeah.
coordination. But like we don't screen for that in residency application
Yeah.
process, right? And how heartbreaking is it to be accepted in a program, go 3 years,
Yes.
and now you can't graduate, or you're to do something non-surgical. And I don't know, what other programs, how they think of that. I mean, I just wish there was a way to be able to kind of assess the potential, or that surgical potential in the application process. Like,
Yeah.
really come to residency. I don't know.
I think there are some legal issues about testing. I think there's some like stereopsis. Did you prove that someone without stereo is a worse surgeon? I don't think you can say so. It's murky there. I don't think we can do that. I think more of us have been moving our training earlier, meaning like in PGY1, you're assisting, in PGY2, you're doing parts of surgery, so that how do we identify those early? We have to give them exposure early. So it was really hard when I was program director. We had like 9 faculty first. Now we have, 20, 30, something like that. So everyone, we needed to graduate our residents with 150 back then. So I couldn't start so early. And then, but now we're starting at the PGY two year, and we can, and I think you are too. So I think you identify early by early exposure and then structured curriculum. So what do you guys think about 86?
86 to 86.
Yeah, 86 to 86. Many people did not feel that way in the APO.
Obviously the small programs are,
It wasn't even that. It was like, you'll discourage people if you focus so much on cataract surgery. Like the residents think the number of cataract surgery when they're on the interview trail is a marker for how good a program is, right? And then they're saying you're going to discourage people from pediatrics, from the subspecialties that we need, because suddenly they're so focused on cataract surgery. There is another argument that we're preventing the creation of new programs. So there's a workforce issue, and if we put it at 150, then these new programs can't open. And I don't think we've ever, I don't know the history, but what I'm told is that the ACGME has never shut down a program because of surgical numbers. It's, first of all, that's very rare. And again, it accredits programs. So if one of your residents misses the 86, that's not even a citation, Rachel. It's not. Yeah. So I think there's some misconceptions, and
we're creating the cataract surgery, so every other specialty goes on a fellowship to maximize their surgical potential.
Yeah.
The question is, what is enough? How much do you need to learn while you're training before you go to that?
Right. And we didn't talk about like complexity. So all of these, like you can do 150, 20, 60 cataracts and feel like you're competent, but you didn't do the ones that you really kind of need to be exposed to. And there's no way that, I mean, that's just too complex for the certainly ACGME, but that should be built into your curriculum, I think. Like, when do residents get exposed to the tougher cases? When do they struggle? How far do you let them go? I mean, I think those are some of the questions that our educators continue to struggle with. So I'm with you.
Thank you very much.
Thank you.